Tato, welcome again. I'm Pauline. I'm part of the Mobile Health, Rural Health Professional Development Team. Today's webinar is an immunisation update. The Advisory Centre, IMAC, is based in the University of Auckland School of Population Health. The service provides a source of independent, factual information based on international and New Zealand scientific research regarding vaccine-preventable diseases and the benefits and risks of immunisation. It's training for health professionals, coordination of immunisation services nationally, and research into many aspects of vaccines and vaccine-preventable diseases. And today we've got two presenters from the Midland region. Jude Young currently works as an education facilitator and is also an advisor on the 0800 line. Maria Crawford is an immunisation education facilitator based out of Hamilton.
Thank you, Pauline, and thank you for inviting us to present today. Just so you know who we are and where we come from, I'm a Hamiltonian and I've been nursing for the past 30 years, which is a bit scary to say that. A lot of different places, but mainly in the last 20 years, definitely practice nursing and then a clinical nurse specialist in infection control and then sexual health. So that's my background, and now I'm with immunisation.
And I'm Maria, and I've been nursing for 20-something years as well. You do start to sort of not want to say after a wee while. My primary background has always been paediatrics and public health nursing, and in amongst that, a few other sort of roles that all still lead back to this core interest of mine, which is preventative medicine and immunisation. So now we're both in a bit of a dream job because we get to talk lots about something we're very passionate about. So it's a great pleasure to be with you today.
Cool. So Maria's just going to slide out of the screen and I'll take the first half and then we'll swap over for the second half. So first of all, we understand we're talking to a wide range of health professionals today. So this webinar is a general overview of immunisation, the recent changes that have come in this year. There's been a few, and just at the second half, addressing some common myths that often come up over and over again and having those immunisation conversations that we all come across, and then we're going, how do I answer that? So hopefully you'll get something out of this webinar today, just taking little bits that you need for your area, because you as healthcare workers play an important role in supporting patients and parents' decisions around immunisation. You're a trusted source of information. So just having a little bit of an idea or knowing where to go is so important to directing them to the right place. Go. There it goes. Okay, so who are we? Pauline's basically covered who we are. Immunisation Advisory Centre was established in 1997 and it sort of started with 2 people and has expanded to be a nationwide organisation. We are based out of the School of Population Health at the University of Auckland, and it's all about making sure that we've got factual information and the research behind us for the information that we give out. So there's a demand out there from both health professionals and the public. We are not the Ministry of Health, but we are contracted to provide this service. And one of our core things is that we do all the vaccinator training courses around, training people to be vaccinators. So why is immunisation important? Well, basically, it's the most effective way to actively protect people and individuals from preventable diseases, such as whooping cough, tetanus, hepatitis B, and measles, to just name a few of them. So it's a chance to prevent diseases. Our very young children are particularly at risk of becoming sick with these diseases that we vaccinate against because their immune system lacks the experience and is unable to respond as quickly, obviously, if they get these diseases. The other thing is it's about protecting communities. So with all of the information out there about COVID this year, people have got to learn some terms, including things like herd immunity. So high immunisation coverage means that we can protect more individuals and they in turn protect their families and the wider community. And it just means reducing that spread of disease to those who cannot be vaccinated, such as the very young or the immunocompromised. Some diseases we could have already eradicated if our immunisation rates we're high enough. We can say smallpox has been eradicated, but we're still working on a few, such as polio. So polio is on the cusp of being eradicated. There are 2 areas in the world that still have wild polio. That's Pakistan and Afghanistan. But a momentous announcement was made this year, but once again, probably got lost in the noise of COVID, was that Africa was declared polio-free by the World Health Organization, and after 4 years without a case. So that's pretty significant and a great achievement. I've written there global travel. Well, it's not a lot of that happening at the moment, but that's always our biggest risk as an island nation, that, we will import diseases from other places. And that's how measles was introduced here last year, was from someone who'd caught it overseas and brought it in. And then unfortunately, we exported it, they believe, to Samoa. We give different vaccines for different reasons, not just one reason. So first of all, there can be no treatment for some of these diseases. Pertussis in particular, or whooping cough, which is always lurking in our community. Antibiotics such as erythromycin can actually reduce the spread of the disease, but it doesn't actually cure the disease. So you're relying on that person's immune system to fight off pertussis and also things like measles. And so a lot of the care there is only supportive. The other thing is we can have some excellent treatments, but because of the nature of the disease, it doesn't always guarantee a good outcome. So we have very effective treatments for things like meningitis with our antibiotics, but it's so fast that it can hit so fast that by the time we recognise it, it's too late to be effective. And same with meningococcal and the Hib. We do have 2 vaccines that prevent cancer, which is pretty amazing to be able to say. We'd love more vaccines that prevent cancer, but for those 2, hepatitis B preventing liver cancer, and then the HPV, human papillomavirus, preventing those cervical cancers, but also other genital cancers and the mouth and throat cancers. So that's a significant vaccine. And then some of these diseases just have serious complications and comorbidities. Thinking of the rotavirus, where you get severe diarrhea leading to severe dehydration with your very young babies, ending up in hospital. Since the vaccine was introduced in 2014, they've had a significant decrease in paediatrics hospitalisation rates by about 85%. So that's the impact that vaccinations can have. All countries around the world have a version of a national immunisation schedule, but it is very individualised to that country. So they're all slightly different. And it's all based around what is happening in that country and what is their most risk. So for us, definitely pertussis control is a key aspect of how the schedule is worked out, and also measles, which we'll talk about very much this webinar. This question comes up a lot, as in who's eligible for publicly funded vaccinations. So first of all children who are under the age of 18 are entitled to or publicly funded for vaccination regardless of their immigration status. So if you've got someone who's visiting from overseas or at the moment stuck here from overseas, then they can, and they're under 18, they can definitely have the publicly funded vaccinations, and there should be no charge added on for an immunisation visit. If they're over the age of 18, they need to be either a New Zealand resident, a registered refugee, or have a visa which provides health services. And then there are exceptions, as there always is with immunisation. With the HPV vaccine, it's actually funded up to their 27th birthday. So if someone has it when they're 20, the day before they turn 27, their first vaccination, they can complete their whole course of 3. If they're a non-resident, as long as they start before they turn 18, they can complete after they're 18. So there's been some significant changes this year with the schedule, and part of that is also updating the Immunisation Handbook. So So this is the latest version, 2020, and it's only available online. So the Ministry of Health says they're not going to be doing any hard copy, print any hard copies, so you do need to use the online version. It's been updated a couple of times this year as the changes have come in. So if you've got any old ones, please don't use them and we'll get rid of them and use the online version. So we'll just talk about the schedule changes. Here's our schedule change, our overall schedule. We do say that babies' first immunisations don't actually start at 6 weeks, but start when they're still in mum's tum. And that's at every pregnancy. A pregnant lady can have the influenza vaccine and also a Boostrix, which is the diphtheria, tetanus, and most importantly, the pertussis part of that vaccine to protect baby. And Maria's going to talk about that aspect. Then they have their primary course at 6 weeks, 3 months and 5 months. And the change in July was that the pneumococcal vaccine was taken out of the 3-month visit, and we'll detail that in a moment. And then there's been one visit has been put into 2. So there's been some timing changes at 12 months and 15 months. And this is all about getting 2 measles, mumps, rubella or MMR vaccines in by their 2nd year of life. Further along, then they get a booster at 4 years for diphtheria, tetanus, pertussis again, and the polio. So that is at 4. It's not just before they start school or a before school thing. It's by 4 that they should be having that Infinrix IPV. Then we have the ones that are often given in the school-based program, definitely in the North Island and some places in the South or in primary health. So at 11 years and 12 years. So that's another check-in where people sometimes get missed. So we always say, look, by the time if you're checking your 14-year-olds or if you're working in that age group, that's a good time to make sure that they're all up to date with their vaccinations that they're funded for. Then at 45 and 65, there used to be an adult diphtheria tetanus, but now it's become an diphtheria tetanus and pertussis. So again, this is all about reducing the circulating pertussis in the community and protecting our little babies from whooping cough. The other thing at 65 is they also get a free flu vax every year, and just one shingles vaccine is funded. So why the change with the pneumococcal vaccine? Basically, research shows that 2 doses of the PCV10 given 8 weeks apart and a booster at 12 months is just as effective as having a 3-dose primary course at 6 weeks, 3 months and 5 months. So it's actually 1 less injection for baby at 3 months. And, parents will definitely appreciate that change. The other change was having 2 visits, 12 months and 15 months. Why again? Well, in 2019, the measles outbreak, in that outbreak, over half the cases were in the 1 to 2-year-old group were hospitalised, so a significant amount. So giving both the doses of MMR protects this age group earlier and helps improve that uptake of that second MMR, which was usually given at 4 years. So again, sometimes that got missed. It also means with these vaccinations spread over 2 visits, if there is the potential to add more vaccinations if more become funded. So if we start funding or the ministry funds a meningococcal or needs to add something, there's space to do that. Going to mention about immunisations of special groups because these do get missed and people do sometimes forget to think about them. So this is when you have additionally funded vaccines or extra doses for children and adults with particularly complex health needs, because obviously they're more vulnerable. So this is just a list of various groups, and more detail is available on our website or in the handbook. But if you're in an area that, use it and you've got people with some complex medical conditions, just maybe check out whether they're entitled to some extra funded vaccines so that they're to protect them and to extend their protection. The one at the top there on the left, adolescents and young people living in close living situations, that's a fairly recent one. It was introduced at the end of last year. So those people who are aged 13 to 25 are now funded for one dose of the meningococcal vaccine, A, C, Y, and W, Menactra, if they are entering close living conditions such as halls of residence, boarding schools, going into military barracks or prisons. So just another check if you're working with that group, or even if you've got someone in your family and you're thinking, oh, they're heading off to uni next year, they are entitled to that meningococcal vaccine. Another change that came in October this year was in how we administer some of our vaccines. Historically, New Zealand has recommended that all live vaccines be administered via the subcutaneous route, and that's because that's how the initial trials and research were done. But inevitably, sometimes they got administered IM, so they actually started studying to see if it was administered intramuscularly, did that change the immune response? And what they found was no, it was just as good. And they also noticed that they had fewer injection site reactions. So that has been already in place in the UK and Australia, where they routinely use the intramuscular route for their live vaccinations. So, and it's also supported by the data sheet. So with this change coming in, we are also going to follow that. This is just an example of the difference when you give Zostavax, the shingles vaccine. This was one of the studies they did, and you can see it's actually quite significant, the localised reaction after they've had it intramuscularly versus subcutaneous. So majority of our vaccines on the National Immunisations Schedule are now given intramuscularly. So the 3 live vaccines, MMR, varicella, which is your chickenpox, and Zoster, the shingles, will now all be given intramuscularly. The injectable polio vaccine still does get given subcutaneously. Right, we're going to talk about measles next. If anyone can remember, a year ago, seems like a long time after this year, but there was a measles outbreak last year. And this, as I said earlier, has had an impact on changing the schedule. So the number of confirmed cases was over 2,000. The outbreak sort of started in July, August, and then really ramped up in September. And it was mostly in South Auckland and then the wider Auckland, Waitemata DHBs. But then there were outbreak little pockets all over the country. Over a third were hospitalised from these cases, and significantly only 7% of cases had 2 documented doses of the MMR vaccine. When you break it down into age groups, you can see that there's some real at-risk groups. So the under 4s, and particularly the under 1-year-olds. So MMR vaccine is not given to under 1s routinely. It's always from 12 months onwards. So this is where this community immunity is so important about protecting those that can't be vaccinated. The other big group, as you can see, is in the 15 to 29-year-old group, and there's a couple of reasons for that we believe. One is that there was a paper that came out, and Maria's going to touch on this, about MMR vaccine linked to autism, which has been totally discredited, but that was 22 years ago. So you can see who falls into that age group. And there was also a schedule change also about 20 odd years ago, where the MMR vaccine for the second dose was changed from 11 years to 4 years. So there's that big group that some of them never got their catch-up vaccine. So all these things impact on our immunisation rates and leaves us with some pockets of under-immunised age groups. Hence, there is now a measles campaign for this year and next year. This was going to kick off probably earlier in the year, but it has been delayed because of COVID, but is now back on track. So this is going to be led by each individual DHB and how they target and how they roll that out. So you will see more and more information coming out because it's pretty much in the early stages. A particular focus is obviously on capturing that large 15 to 29-year-old group. So again, if that's an area you work in or if they come in for something else, and if you're in a GP practice, always check their MMR status. Any opportunistically moments, take advantage of. What is an acceptable evidence of immunity for measles, mumps, rubella? This one comes up all the time and it's really quite clear in the handbook, so please refer to the handbook. Firstly, history is really important, taking a good history. But if people are born before 1969, they are considered immune regardless of any serology. And that's because measles was circulating in the community and everyone got exposed to it. Whether they got sick or not, they would have developed antibodies against measles. If there's a history of 2 MMR vaccines, then they again are considered immune regardless of serology because it's such an excellent vaccine. So if you've had 2, you're considered immune. If you've only had 1 and you're, as I say, born after 1969, then you would have a second one and avoid pregnancy for 4 weeks because it is a live vaccine. And obviously it's never given to a pregnant woman if it's a live vaccine. And if there's no history, then you would do 2 MMR vaccines 4 weeks apart or a month apart. So that's what's considered evidence of immunity. Serology is not required or recommended because it can be unreliable and give you a false picture. So it's all about how many doses of MMR they've been given, 2 doses, or if they're born before 1969, they're considered immune. And just the other one, because we did say we'd focus a little bit on adolescents, is the HPV vaccine or the human papillomavirus. So really a very common virus, easily transmittable, and pretty much 4 out of 5 people will have contact with the HPV infection once they become sexually active. But of course, it doesn't always show symptoms, so a lot of people don't know they've got it. But we do have a vaccine which is highly effective, and it was introduced in 2008 with a 4 strain, the Gardasil 4, and that covered the 2 types that cause genital warts, and then the really 2 nasty ones that go on to cause cervical cancer. It was only given to females to start with and various age criteria, but in 2017, great change, that they decided that they would include all males and females and vaccinate those aged 9 to 26, and covering 5 more strains of HPV that have been linked to various cancers. So how did that impact? Quite significantly. Not just, these are some of the studies that they've got some numbers out of, but also in sexual health, the clinics there reported significant declines in presentation of genital warts in both men and women. And that's fantastic, because at the end of the day, that's what the young people are worried about, are those genital warts. Cancers in the future don't really register, but when you say about a vaccine that can prevent genital warts, a lot of them are very, very keen. And a lot of them don't know about it. So definitely the boys, the males, a lot of them are unaware that they can get this vaccine up to the age of 27. So something to just put out there again and talk to your patients about. So this is the schedule at the moment, and it has changed slightly again, in that if they have their first dose of Gardasil vaccine before they turn 15, they only need 2 doses. So again, reducing that number of times they have to have an injection is a very positive thing. But if anyone starts it over the age of 15, they do need a 3-dose course. So that's been a recent change as well. Okay, so I'm going to now hand over to Maria, and we're going to do a chair swap.
Hello, everybody. That was seamless, I hope. So I'm going to pick up where Jude has left off, and I'm going to move through a couple more things around our priorities that we have in immunisation, and then look to also talk about a few of the myths and misconceptions that come up and some of the non-barriers that we have to immunisation. So Pregnancy, vaccination. It's such an important topic, but it's sadly a topic that sometimes gets a little overlooked. It's a big body of work that we undertake working with midwifery students, midwives themselves. We do a big push around this with our nurses that come on our courses and our pharmacists, because it's really, really an important aspect of immunisation and probably a little misunderstood. So it takes us right back to the basics of why do we do this? We know that a pregnant woman, by the sheer science of her being pregnant, she needs to have some of her immune system re-regulate, basically, so she doesn't reject her baby. So in that respect, when we're looking at maternal immunisation, because she does have a T-cell response which is regulated and reduced, we want to protect her. So influenza, we're looking at protecting her against any of those really catastrophic effects if she was to become unwell with influenza. The other thing with pertussis and influenza is that we know that we get a really good specific IgE antibody passing across transplacentally, and it's a really, really good cord level that we get from that. So that means that we know that the baby is getting some really good protection from mum. One of the common misconceptions that we hear out there sometimes is that the baby is getting the vaccine. So it's really important that we are talking to mums, expectant mums, mums who have brought their children for immunisation, because remembering they may not have heard about this before themselves, that they understand that mum does all the work, basically. She has the vaccine, she creates the antibodies, and she passes that precious little gift across to the baby, and the baby then gets protection. It's really, really important to know as well and understand that that protection is really important. If you think about pertussis, we know that babies don't start their primary course of immunisations till 6 weeks. So we're giving them that protection by vaccinating mum. With influenza as well, we also don't have a vaccine that we give to under 6-month-old babies. So by mum having her vaccination, we're again giving baby protection for that first part of their life as well against influenza. So as I say, it's a really important aspect of our immunisation program. It's a focus not only for us here in New Zealand, it's a global one that the World Health Organization also want more work done around. So really, really important body of work. So the other thing Jude alluded to is we know that pertussis is always lurking, and you'll all be aware that we have come back to the more expected, and I say expected levels because we had COVID come along that's interfered with quite a few levels recently, but we did have that rather nasty outbreak, and really in 2018 you can see a peak there where we did have a lot of cases happening, and we had over 4,697, and I mean, any of us that have ever looked after a baby that has had pertussis or is dealing with pertussis, we know how awful that is for the baby, the parents, and the healthcare professionals, because there's not a lot we can do. It's very supportive treatment that we have to give them. So we really want to be able to make sure that we're getting good herd immunity around this. We know we have a vaccine that wanes, and we know that that immunity from natural exposure to the disease wanes as well. So vaccination does remain our mainstay, and particularly maternal immunisation is a really precious way to start making sure that we're getting protection happening out there for our little ones. So you'll all be aware that last year in July there were some changes made, and basically Pharmac and the Ministry funded the maternal immunisation for Boostrix from the second trimester for every pregnancy. So what we're wanting to do with this is we're wanting to give it with enough time for mum to mount that really good immune response and to create the sufficient amount of antibodies to transfer over to the baby. So that's why we say from 16 weeks and preferably by 28 weeks. It's not saying that if we do give it over 28 weeks that it's not going to have any effect. It just won't have as a robust effect, basically. So those are the timeframes that we've put there to make sure that we get some protection for those babies. Pharmac also, at the time that this was changed, also extended the eligibility of the Boostrix vaccine to include parents or primary caregivers of infants that are admitted to the neonatal intensive care units or the specialist care baby units for more than 3 days. And at that time as well, mothers who did not receive any maternal immunisation, we make sure that they get vaccinated as well. Because the other thing with pertussis as well is we don't want mum picking up pertussis and inadvertently being able to spread that to the baby as well. So it's really about kind of blanket protection as well. So I'm not going to go too over the top in your lunch hour with stats, but just to show you that influenza, we have had this little thing called COVID happening this year that has actually meant that we've seen a reduction in our influenza-like illness out in the community. I didn't think I'd ever say thank you, COVID, but that's a yay that we actually saw a reduction in that. We did have an unprecedented uptake of the vaccine, which was fantastic, but it does really remind us too that we have to keep on our toes and be prepared for next year. So just a reminder that each year we will, at the start of a year, have a flu symposium, put webinars on our website. We send out a flu kit to you all. The flu kit is an amazing resource for you all to know what the eligibility criteria are for the year, what the vaccines that are going to be used are, what any particular promotions we're doing, such as for maternal immunisation, are in there. So making sure that you do keep an eye out for that is really, really important. And have conversations with anyone that has anything to do with children. I think getting a maternal immunisation message out there is really, really important. And we have a lovely little video on our website that's really helpful as well. When we talk to a lot of our colleagues out there in the field, we've got some that are showing these in GP practice waiting rooms. We've got some of our OIS teams that have it on a tablet to show, and it complements some of the written information immunisation and pregnancy as well. So we aim every year to make sure you've got lots of tools and resources that you can use as well in trying to achieve what we're overall trying to achieve, which is increased immunisation rates. So just in summary, kind of tying together what Jude has said and what I've just covered off as well. So we really do have our priority groups that we really do focus on. Obviously, pregnancy I've just touched on. And like I said, it's really important we have conversations about this and start to really normalise that this is part of the immunisation schedule. Our infant and childhood vaccinations on time, every time are really important. Anytime we have delays, then we know we've got children that are exposed to vaccine preventable diseases, and we just don't want that out there. Jude talked about the team immunisation check, really important that, we also consider that sometimes when the vaccines are predominantly maybe delivered in a school-based program, for instance, some people might not opt to have it in that sort of arena of having a vaccine. They may change their mind. It's always really good to be revisiting and seeing whether people have changed their mind, if they are now actually, willing to move forward and even start vaccinations. The other thing is to remember that we do vaccinate across the lifespan. So as you sort of move past the teens, start thinking, like Jude said, about those that are entering into tertiary study. The police, armed forces, health, all of those will require vaccination history. So really be checking, is there anything we've missed? Is there any vaccines that they need? And it's never too late to start immunising. And obviously our adults are really important as well. And Jude mentioned that, making sure that they are getting what they need to have, and making sure we're considering our flu, our Zostavax, making sure that those special groups are taken into consideration. There's a lot of people out there that can be eligible for additional vaccines that are funded. They just don't know that. Another thing that we often talk about with a lot of our nurses in particular is optionistic immunisation. Basically, when we see these people in our practice settings, it's a really good opportunity to be checking immunisation status for all age groups. But for children in particular, it's really important if we've got those infrequent attenders and we've got them there, making sure that we use that time wisely, and we do look to make sure that we try and get them caught up on their immunisations. We always have our 0800 line available during the week, during the work hours. I wish it was 24/7, but we can't quite do that. But it's always there as well, so that we can make sure that we can look at doing catch-ups as easily as possible as well, and making sure that we start to think innovatively about how we can also provide services for people. So I know Jude and I had a session last week where we had a lot of our OIS colleagues who are really working hard at the moment to try and find a lot of families with practices, because we acknowledge too that there's also been some sort of some issues around COVID and accessibility. So there's a lot of work going on trying to optionistically catch everyone up as well, which leads perfectly to talking a little bit about some of the barriers to immunisation and just sort of giving you an idea about some of the resources that are out there to help with that. So how are we doing in New Zealand? So this is for the latest quarter up until September. Bearing in mind, our goal for immunisation coverage is 95% of children to be fully vaccinated by 2 years of age. So when we're looking at this, and also the target markers for on-time vaccination is 95% by 8 months, 2 years and 5 years. So you can see by these numbers, we've had a dip. And we have to take into consideration this has been a very, very different year, and we have had a lockdown. So that's obviously affected. But there's a lot of work that we're doing, trying to get the access back up and running and making sure that people have the confidence to access the immunisation services. You'll have seen the ministries put out information around that. But it'll be really interesting to see what happens over the next 6 months or so to see how we build that confidence back up and make sure that people are re-engaging and we are getting those immunisations on time with people. It's really interesting as well that vaccine hesitancy has now I'm just looking at that thinking, actually, I think next year the World Health Organization will probably have COVID at the top of the global health threats there. But these were the ones for 2019. And it was the first time that we saw vaccine hesitancy actually acknowledged as being a problem and an issue around vaccine uptake. So it's a really important thing now that globally we're looking at this because we have known historically that there is a problem with it here in New Zealand. And we kind of look at vaccine hesitancy and break it down into a continuum really. So all of us in our clinical settings, we will have those people that we know accept it all. All vaccines are just normal for them. They're the proactive ones that come in on time. You do a recall if they might be a little bit late and that in lickety-split because they know they want to get it done. We've got the other end of the spectrum, which is our refuse all, and we all know about those particular people as well. They tend to be people that we're not going to change their views. They're very steadfast on their beliefs around immunisation. But the crucial area and the people that we need to spend the most time with are those ones in that blue section there. So these are the people that are accepting of some of the vaccines maybe, or they're delaying because they're a bit unsure, or they've just got some mixed messages about how you can proceed with vaccination. And we'll talk about that in a moment as well. But really the important thing to remember is that this is the group that we really do need to spend some time and focus with helping them navigate this decision process. So there's some stuff that we just can't change. There's some circumstantial reasons that people don't access immunisation. We live in a very rural population, some of us, so there could be access issues, transport issues, financial issues. I have a background in public health nursing, and I can probably tick off most of these as being something that inhibited people from accessing immunisation at some point. We also have a lot of change in our community now where people are working. We have 2-parent working families where literally they can't get time off work to get children into clinic settings and so forth. So there's some of these things that are circumstantial and we can work within our processes and so forth to try and accommodate and try to assist people with this. But really the challenging area is when we're looking at the emotive reasons that sometimes parents delay vaccination. So these can be things that are a little bit more hard to unravel and to get to the core of what the issue is for a family, for instance, but it could be fear and anxiety. One of the things we're hearing a lot is not wanting to come to a general practice at the moment because of COVID. You know, there's that natural fear, you know, what if I'm going where there's sick people? Whereas actually a lot of the practices have done amazing things to make that safe for people to come to. We have a lot of influence that happens out there, social media being one of the biggest challenges we have. And that is where we can see a lot of misinformation and myths coming around. But when you're sitting on the cusp of making a decision like this, those are the things you hear, and those are the things that can affect your decision-making process. We still have some people out there too that is just a real general fear. They've got this precious little baby that is so dear to them and they just don't want They don't want them to get sick with the disease, but they also don't want them to have the pain of an injection. So things like that can be emotive, and they can be the reasons that some people will delay and not access immunisations in a timely fashion. We do have a couple of myths, and these come up quite a bit within our trainings, but also on our information lines and so forth. And one of the key myths that we still hear out there concerningly is this one. So MMR causes autism. Now, we know that that is not the case, but sadly, back in 1998, when that British physician, who we won't name, raised the notion of MMR potentially causing autism, there was no scientific basis to it. We know that the Lancet retracted all of that information, but unfortunately, the ongoing repercussions are still felt now. And we still have parents who make that link because it's a myth that they've heard and heard and heard and heard, and via social media and so forth. And so it feels real for them. So we have to back that up with the science of us knowing that that is not a true and factual notion. So it's about making sure that we spend the time to break down that barrier with parents, and also that they actually understand, because we've also got complacency around a lot of the diseases. And prior to last year, when we had our MMR, our measles, outbreak, there was complacency about measles. It wasn't seen. So if it's not seen, it's not thought about so much. So it's about making sure that they understand that actually these diseases are very serious, they're very real. And this myth in particular is not a true and factual one. There is no scientific background to it. Another one that comes up quite often, and we get this a lot, even in our trainings, is that vaccines contain toxic chemicals. And it really, whenever you get asked that question, you think, well, how do I explain that? I think the biggest thing is if you can try to give examples of everyday life and reassure people that vaccines are highly regulated. Everything that goes into a vaccine, whether it be the antigen or any of the other ingredients, has to be registered and listed in even its minutest amount. If you can relate it to something that's a daily occurrence, people start to understand actually what's in a vaccine I actually use anyway. So, for instance, eye drops, they often will have a preservative in them. I mean, I put my makeup on every day. That has a lot of preservatives in it so that I can actually manage to put on a good foundation cover. But I need the preservatives so it doesn't go off. It's the same in vaccines. We need to have those in there to make sure our vaccine's viable. Aluminium comes up quite a lot. Aluminium's found in drink bottles. So you can see I always have like a few little prompts with me as well when I'm having a conversation with parents to just give them some real life examples of what's out there and what we use in our daily life that you would find in a vaccine, and it kind of normalises it for them. Everyone can relate to ice cream. Well, polysorbate 80 is in ice cream. So in saying that as well, it's about context, very much about context. So have a little look at this and have a little think to yourself, would you consider drinking this cocktail? Everything looks pretty scary, I would think, and scientific-y in that, but actually it's your classic cup of green tea. So it just shows you that the context that we use with some families, and when we're having conversations to sort of debunk some of this misconceptions and confusions about vaccines, it's really important to put context to it as well. And that's why I love to have my little prompts and talk to people about what we have every day that has ingredients from vaccines in it as well. Another one that comes up quite often is, and this is remembering these are their precious little babies, is do multiple vaccines overload a baby's immune system? Well, in short, it's pretty much impossible to do that. Basically, an infant's immune system could respond to so many vaccines at once. It's the amazing little babies that are born into this world. But it's a real concern for parents, and remembering that they want the best for their babies. So sometimes they'll think that they should delay because their baby's too little or too young. And this can be a real fear for them. So it's just remembering to reassure people and just to think about, go back to the science. We know that these babies have this innate capacity to respond to multiple antigens as they start to grow, as they start to walk and put things in their mouths and so forth. They're always learning and being able to respond to these antigens. And actually they have more T and B cells than adults. They're able to respond to things a lot better than we are, because as we get older, everything starts to diminish, sadly. And the other thing that we love to remind parents about now is if you think about vaccines of old, And the vaccines we use today, we actually have very few antigens in them. So they're very, very safe, and the science has allowed us to do marvellous things with our vaccines with very few antigens in them. Just following on from that a little bit too, is some of the questions we sometimes get is, what about premature babies? Sometimes parents have this desire to wait because their baby's been born prematurely. We actually know that they are very much at risk. So we want to vaccinate them as per the schedule, so at their usual chronological age with the usual vaccines and intervals. So the only time we would maybe be a little bit cautious is if they are still in, say, intensive care with some additional issues, then your specialist will guide you on that. But, you know, it's not a reason to delay because they're premature as a reasoning on its own. Some common reasons people don't vaccinate, and we can. There's a really fabulous section in the handbook because, again, this is just one of those reasons that people sometimes will delay, is because of that misunderstanding of what it is that would actually be a contraindication. So the best thing we can do as health professionals is be very clear on the contraindications for vaccination, and then that means that we can make our clinical decisions and unravel some of the other things people might present with and try to delay their immunisations with the best of intentions, but actually knowing there's actually not that many things that would stop us from giving a vaccine nowadays. So I'd highly recommend going and having a look in the handbook, because there's a really good section on that in the new handbook. The other thing to think about is, and this is the difficult one, is not leaving conversations for others. So when a parent brings a concern, if they're that group that is sitting on the fence, it's really important that we do take that concern seriously and we respond as quickly and as appropriately as we can. I know that can be super difficult when you're sitting in a consult room and you've only got 15 minutes, but it's also acknowledging that when people are sitting on the fence, you may actually have to have multiple conversations to be able to reassure them and get them to a place where they feel confident with the decision that they've made. So it's really important to always document your conversations you have. Use the resources that you have around you. You know, there's a lot of information out there that's scientifically based. And if you're giving links to parents, make sure that you're giving them links to really good, solid, research-based links. We don't want them going off to Dr. Google and getting the worst of information. We want them to go somewhere where they know that information is valid and really has been researched and peer reviewed and so forth. It can be really, really hard to change philosophical views, and sometimes that's where you do just have to remember that you can sometimes be the best help by actually just saying, no, that is not true. For our very, very much so people that are just kind of trying to invoke an argument with you. But those ones that are in the middle, that want the information, they need the information, give it to them and share as much as you can. And be honest too. A lot of the times I've been asked some questions that I don't know the answer to, but I actually acknowledge that and say, that's a fantastic question, let's find that answer together. And they come on a journey with you to find out the answer, which is always really rewarding. So just in summary, some top tips around that communication, because it can be really, really hard when you've got people that are just unsure about vaccination, and immunisations and vaccines, and there's a lot to try and think. I think it's about taking it back to the basics, making sure that we're acknowledging any fears and concerns, connecting with the person and finding out the core of what the issue is, and then you can break it into sizable chunks where you can kind of deal with any myths and misconceptions that might be in there. It might be as well that, like I said, you're going to be repeating this. There'll be multiple visits or talks before you get to a decision time with parents. The big thing to remember is to try and avoid using any negative terms in repeating any fear-based statements or myths, because basically all they hear is that myth repeated and they don't know that we've actually sort of dispelled that. They've just heard it repeated. So making sure that when we are communicating, we're very clear, and we're making sure that we're giving them the best information that we can. And there's a wealth of information out there, both outside New Zealand and in New Zealand, that can help you as health professionals with the resource to do that. So just to show you as well, so I'm sure most of you use our website, but the website is a really good link to go to. That's where you'll find information for health professionals to be able to decipher information. There's information on there for parents. There's lots of opportunities for short courses for health professionals on there. We put up anything that is relevant and that is being heard out in the community to try and address it as quickly as we can as well. But we also do lots of webinars for yourselves as health professionals. We're getting very, very good at webinars now, New Zealand. So we have webinars up there and opportunities for you to interact. We have our 0800 line. So there's lots out there, but then alongside that, you've also got things like World Health and all those kind of fabulous sites to get additional information as well. The other thing is, don't forget that the entire team that you work with are really important in this journey as well. So on our website at the moment, we've got a really good video that's aimed at reception staff, for instance, so that they have the confidence to understand the immunisation process and the importance of the key elements to it, and also as that first face for people that come into a practice setting. So it's just a way of involving everyone and also giving everyone good information to share. And then this is an oldie but a goodie, and most of you have probably seen it, but this is a really good little clinical myths clip that we have on Vimeo that's really, really helpful as well. A lot of parents can watch this, and it really dispels some of those misconceptions and concerns that they have out there. And then obviously we've got great supportive documents that come through that support the immunisation pathway as well. So that brings us lickety-split to the end. So Jude's going to come back and we can answer any questions that you may have. Sorry. That's all right.
I'm muted.
There you go. I can hear you now.
I know exactly what I'm doing. So we've got a few questions, and while we're looking at those, maybe some more will come in. But actually, Anne-Marie has asked two questions. Her first is, she says, as an occupational health nurse, how can I include the National Immunization Schedule into my professional remit? And then her second part came in, must I review my immunisation schedule? So she's an occupational health nurse.
Occupational health. Okay, so on our website, there is some good information on there for occupational health nurses. We know that a big body of your work generally does sit around influenza each year. So I guess really it is about going on our website, watching any of the webinars that are relative to the national schedule changes. So we did a really big webinar when they came in October. And on there's a little bit more that might be relevant to you. That today we've sort of done a bit of a broad overview. But if you go back onto our website and have a look, there is some webinar on there about the national schedule changes, and you'll probably be able to find what's relevant to your area of practice on there. Does that help?
Fantastic, good. And Cheryl says, how can you be considered immune if serology shows otherwise?
Jude,
I knew I was going to have that. Okay, I've got to get this straight in my head as well, because it is a bit of a tricky one. Basically, serology is picking up circulating antibodies. So if you haven't been exposed to a disease that you've been immunised against recently, you won't have any circulating antibodies, but you will have memory cells that will kick in once you're exposed to that disease. So if you take a blood test, it might not show up as having immunity. And this comes up with the hepatitis B vaccine, where people have had the full course, then do a blood test, it shows no immunity. So if we give them one dose of hepatitis B, which we call a challenge dose, it actually switches on the memory cells because they've been exposed to some hepatitis B, a small antigen. It's enough to kick in the memory cells, and then the antibodies start circulating. So if you do a blood test about a month after you've given a challenge dose of hepatitis B vaccine, it almost always shows immunity to hepatitis B. So that is how it works. That's why it can be unreliable, in that if you haven't been exposed to the disease recently, your antibody levels in your blood disappear, but you have memory cells that will kick in if you are exposed to the disease again. So you do have immunity. That's why they rely on the 2 documented cases of vaccines of MMR. Hope that helps.
Well done. Now, we've got a question from Chink. Kia ora, Jude. Would you be able to go back over the deadline age for the HPV and MMR catch-up? Could you go back to that screen, please, and show it again? Is that something you can easily do? Yeah. Just share your screen again and go back to it?
Yeah, so for Gardasil, they basically, the time limit is before they turn 27, between 9 and 26 is if they're New Zealand residents or hold a visa that entitles them to healthcare in New Zealand. Here it is. Oh, go. I'm sorry. And start before they're 15, so between 9 and 14, they only need 2 doses of the Gardasil as long as it's 6 months apart, because it is such a good vaccine that they get a really good immune response just with that two dose. And at that age group, just so everyone knows, between 9 and 14, you have a wonderful immune system that just converts lots of things into good immunity. So that's why they only need a 2-dose course at that age. And then if I go back to the MMR criteria, there it is. Yep. So the firstly is what day, what year they were born. So born before 1969 is really important because they are considered immune because of the circulating measles disease in the community. So everyone of that old age group will have immunity. And then the basically 2 documented doses of MMR vaccine, as long as they're given a month apart, and when they're given, they're older than 12 months of age, so 1 year onwards, that's considered proof or acceptable evidence of immunity. And it is in the handbook if you need to refer back to that.
Just remembering the handbook is now only online,
yes.
Which is a challenge for some, we know.
So Cheryl's come back about the serology question. She said, thank you for the answer. We still had 7% of the MMR cases with 2 doses of the vaccine.
Yeah. So no vaccine provides 100% immunity. So for whatever reason, but the measles component of the MMR vaccine, with one, they say that about 95% of people will become immune. And then with a 2-dose, that goes up to 99. So so that's a very good vaccine, but then you can't, everyone's individual. So it all depends at, hey, you might have had 2 vaccines, but there will be the odd people whose immune system doesn't respond, and we don't know why. It may be that it may have been an administration failure, but that a cold chain failure. So there'll always be a percentage. But if you get those rates up, that goal that we talked about of getting up to 90-95% coverage, then you will get that herd immunity because the disease can't jump around from one unimmunised person to another. So that's what we're aiming for, to stopgap those people that don't produce an immune response.
And that was the key last year, you will have seen in the outbreak, was we were really, really focused on protecting those that can't vaccinate for any reason.
Or they think they're vaccinated,
yeah,
but actually they didn't, they don't have the protection on board, but you could never really identify those people.
Good. Thank you. Great. Well, thank you. That was really interesting. You covered a lot in a short time, and we look forward to having you come back with some more sort of specific topics in the future. Really good to see more of you. Thank you very much. And thank you everybody for joining us today.
Our pleasure. Take care, everyone.
Thank you.
Yeah. Good afternoon.